Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing about a 50-year-old female patient who came to ER with complaints of breathlessness. So, the 51-year-old female brought to ER with complaints of insidious onset breathlessness. She was having there for the past 2 days, but it worsened that day morning. So, she came to the hospital. So, from my initial 10-second assessment, she was conscious and oriented and obeying commands, and so into the primary survey. Her airway was patent, there was no signs of any hoarseness of voice or any secretions present. Breathing part, she was tachypneic. She was having a respiratory rate of around 34 per minute and SpO2, she was maintaining around 86 with 10 liters of O2. She was actually directly referred from another hospital with O2. So on arrival, she was having only 86% of SpO2 with 10 liters of O2.
Or O2 on which device?
On Hudson mask, face mask. So I changed it to NRBM and continued my examination. On auscultation, she had bilateral crepitations.
What is the advantage of NRBM?
NRBM actually, the range we can give up 10 to 15 liters, and with the adequate seal, we can give more than 90% of FA2. So with NRBM initiated, we continued examination. On auscultation, she had bilateral crepitations and wheeze more over the right side, predominantly on the right side. But she had adequate chest excursions. But air entry was slightly reduced on the left side compared to right. But both sides there were air entry, but slightly reduced on the left side. Circulatory part, her heart rate was 110 per minute and blood pressure noted was 120 by 66 millimeters of mercury. Disability part, she had a full score of GCS, and exposure part, she was febrile, and GRBS was 176 milligram per deciliter. So at this point, 176. So even though actually we planned to start her on NRBM, she was actually significantly breathless. So immediately put her on BiPAP, because actually considering her ventilatory listening effort, we thought BiPAP was a better option. So we started her on non-invasive ventilation with a pressure of 12 by 6, and at around FO2 of 80%, she was maintaining around 90-94% O2. So with that, adjuncts were also taken. ECG was taken, was showing a sinus tachycardia with T inversions in 3 and AVF.
3 and AVF.
3 and AVF. She doesn't have any previous CAD history, non-history was not there. And an X-ray was also ordered to take in portable X-ray taken in ER, and it was showing actually left side opacity. Left side actually and mid and lower zone opacity was seen, more like in favor of a left side consolidation. Her outside X-ray was also similar finding. It was taken one day previously. And then we went to the secondary survey. So basically, she's a 51-year-old female. The only non-case is hypertension on amlodipine. She had a history of insidious onset of breathlessness since the previous day morning, which worsened over time. And the day when she came to the hospital, that day it aggravated, so she immediately brought to the hospital. But the previous day itself, actually, she was admitted in outside hospital with suspicion of LRTA. She was on antibiotics, and X-ray was taken showing again the same features. There was no history of any fever. There was only dry cough, non-productive cough, and there was no history of any other chest pain or discomfort. There was no history of any abdominal pain, vomiting, or any other associated symptoms. And then she was brought to a hospital because of worsening symptoms. There was no other significant past medical or surgical history. There was no history of any diabetes or any CAD history in the past. So on arrival, her last meal was about 6 hours before coming to the hospital, and there was no recent events, anything contributing to the current symptoms. So went to the clinical examination. Again, general examination, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. She was conscious oriented again. After putting NIV, her actually efforts slowly started improving, but she was still tachypneic. And her SpO2 was actually not improving more than like 90 to 93, even on NIV. But her work of breathing was slowly improving with NIV. Then CVS S1 S2 was heard, and abdomen was soft and non-tender, and sensory was still maintaining. She was still conscious and oriented. She was not going into a drowsy state or anything. And also in the adjuncts we took an ABG. It was showing ABG was not showing this thing, only respiratory alkalosis initially.
Tachypnea only.
But considering the symptoms, actually, so far our primary survey was actually stable, except for the ventilatory part, which we initiated on NIV. Back circulatory, everything was stable, but considering her symptoms, she required admission. So we admitted her in our ICU for further evaluation management.
She also had hypoxia, sir. Type 1 respiratory failure, hypoxia was
So what are the criteria to admit a patient with suspected pneumonia to ICU?
We can actually easily so go for something called CUP65 scoring, which has actually five criteria. That is, one is confusion. If the patient is on arrival is having confused state, then blood urine nitrogen more than 19 milligram per deciliter, or her respiratory rate on arrival is more than 30 per minute, and also her blood pressure is systolic is less than 90 or diastolic less than 60, and also an age above 65.
Okay.
So each one we can give a point of 1. And 0 to 1, we can manage the patient on outpatient care, and about 2, we can decide on whether she requires inpatient or outpatient care. Anything more than 3, she requires admission, probably in an ICU. Okay.
According to the criteria, where she should go?
She comes between actually, basically, she was not confused. Her this thing, urea was 28, so 0.1. Respiratory rate was 36 on arrival, so 0.2. But BP and age is negative, so she has 0.2. So we can decide on inpatient or outpatient care.
So
But
these are the problems of strictly following the criteria. Criteria may tell something. You have to see the patient. Okay. This criteria is mainly for pneumonia. If it is pneumonia, what they are telling may be correct. Most of the time, this much pneumonia who is having tachypnea can have some amount of confusion, hypoxemia confusion. But if it is something else which mimics pneumonia, these criteria may not work properly. So you have to be very careful. Each and every patient is different.
So clinically, actually, we didn't feel like this patient was fit enough to go home. So we admitted the patient in our ICU for further evaluation. So
tachypnea is only the major factor in any patient who is having respiratory disorder. Okay, even in spite of giving high flow oxygen, this patient is still tachypnic. That means she is having something else. Okay.
So we sent for routine lab
ABG
investigation.
is taken after giving oxygenation or
In
before?
room.
In room.
In room.
So after admission, actually, we sent for our routine investigations and everything. So initially, her lab parameters, actually, the total count was only 4,000, and CRP came to be 25.
Okay.
And other parameters are almost within normal limits, except for some slightly elevated cardiac markers. CKMB was 3.26, and troponin was slightly elevated.
Okay.
But after in ICU, we also did an echo.
What may be the reason for elevated cardiac enzymes in this patient?
One thing could be stress induced, like
Underlying sepsis, if at all patient has.
The patient does not have sepsis. We are not seeing any sepsis here. It is something else. Okay. What do you think the cause for elevated CKMB?
Respiratory, that muscle.
See, why CKMB elevates in cardiac acute myocardial infarction?
Because of the injury.
Injury of the myocardium due to hypoxemia. Whatever may be the cause for hypoxemia, including a severely damaged lung function which is having very low oxygenation, that itself can produce myocardial injury. Okay. Like sepsis, patient flow is very good, but the oxygen delivery system is not proper. So there also you can get elevated CKMB. So any patient who is having severe hypoxemia for some time, or cardiac failure, or due to any sepsis, all these things can elevate cardiac enzymes. So don't think that cardiac enzyme is only elevated in cardiac failure. Okay. Sorry, cardiac ACS.
So persistent hypoxemia may be the cause for this elevated enzymes. So in the ICU, we also did an echo for the patient, considering his elevated enzymes and all. It came to be like a concentric LVH picture with dilated RA-RV.
Okay. What is the age of the patient?
51 years.
51-year-old. What may be the cause for LVH?
LVH, maybe chronic hypertension.
Hypertension. Okay. Hypertension or diabetes? Both can produce.
She had good LV systolic function, and RV dysfunction was also noted with severe pH.
Okay.
This was the finding from the echo. And also in our routine investigations, we also sent for a D-dimer, because the thing is, actually she came with significant breathlessness. She had tachypnea and tachycardia. As a routine evaluation, we sent for a D-dimer, which came to be positive. D-dimer.
So can you tell about the importance of D-dimer in emergency room?
D-dimer is basically, the thing is, actually it's more in value of a negative predictive value.
Okay. Suppose now it is negative, we can probably rule out
pulmonary embolism.
When it is positive, it can be even still pneumonia. Pneumonia, pulmonary embolism, myocardial infarction. Everywhere it will elevate. Now CKMB is elevated. Your what is the test tool?
Cardiac enzymes.
No.
D-dimer.
D-dimer also elevated. So D-dimer can be elevated even in myocardial infarction. D-dimer positive means nothing. It is nothing. But negative means it can rule out. So it has got a negative predictive value.
So our range is actually, our lab values range is 0 to 0.5. So the lab report we got was 3.15.
Okay, it is elevated.
Significantly elevated. So considering her echo findings, her persistent hypoxia and elevated D-dimer, we thought about ruling out pulmonary embolism.
Okay. X-ray, you got any finding of pulmonary embolism?
X-ray, this patient only had this thing, haziness over the left lower and mid zone. It was the only finding.
No, X-ray, can you get pulmonary hypertension features if there is a problem, like whatever it is, chronic pulmonary hypertension or acute pulmonary hypertension?
Pulmonary
What
hypertension,
change you can get in X-ray?
on the right side we can actually see
On the left side there is a bay called as pulmonary bay. After aorta you get a dip. That dip will become very prominent. Okay. So you have to see whether that is there or not. But here you have done echo, nothing. Echo is more specific than an X-ray. Okay.
So considering her symptoms and actually this echo finding and D-dimer, we sent for a CTPA.
Okay.
Because her creatinine was normal, so CTP was done, and it was showing a bulky thrombus in the right and left pulmonary artery extending into the superior and inferior divisions bilaterally.
Okay.
And the main pulmonary artery measures about 28 and left about 18.
Okay.
And so basically it had there was a big thrombus including both bilateral this thing.
So here you are directly asked for a CTPA. Otherwise, in a patient who is having a consolidation, what are the indications for CT? This is a case of consolidation, or you are seeing a white shadow in the lungs. You suspected or over suspected pulmonary embolism. Actually, in pulmonary embolism, we have to be over suspicious, okay, because many a times it will be missed
out.
Okay, so it is good to over suspect pulmonary embolism. But what are the indications for a CT scan in emergency room in a consolidation?
We want to diagnose any other condition like any malignancy, TB like features.
Most important is malignancy. Then like this, if you are suspecting, if the counts are normal, patient is not toxic, foreign body. That is second thing. Pulmonary embolism, like we are discussing, the patient does not have fever, patient is not having toxicities, and counts are normal.
Patient disproportionately
disproportionately breathless. Okay, not toxic but breathless. There you have to suspect. Like she told, it's foreign body also. Foreign body induced collapse or consolidation. Then also we have to take a CT scan.
So this was our finding in the CTPA.
CT pulmonary angiogram.
CT pulmonary angiogram. And so considering the symptoms, actually we planned her for thrombolysis.
Okay.
So the primary indication was actually she was having significant RV dysfunction on the echo with RV involved, and also she was having persistent hypoxia even with NI, which was not improving.
Okay. What is VQ mismatch?
Basically, in conditions like pulmonary embolism, the ventilation of the patient will be like good enough, but because of the thrombi, some of the areas of lung will be having reduced perfusion.
Okay.
So no matter what we try to increase, like to improve the ventilatory part, the patient will not improve until we clear out the perfusion mismatch.
Physiological dead space increases. So
Physiological dead space.
basically the exchange perfusion doesn't happen.
It's not a dead space. It's not a physiological dead space. Dead space increases. It's not physiological. Okay.
Basically, it's wasted ventilation.
Okay.
So even though some areas are ventilated, there won't be adequate perfusion happening in those areas.
So we have a perfusion VQ scan in our hospital. If CTPA is not available or if we are not able to do it because of the renal failure, then we can try that. But it takes some time. More than CTPA. CTPA is very fast. You'll get report very fast.
VQ usually we use in two phases actually. Initially, we give a contrast to assess the perfusion part, and then we again give a nebulized isotope to assess the ventilatory part. Then we combine these values to get an idea like whether there's any perfusion mismatch. Can you give an idea, especially using case of any contraindication for CTPA?
Okay, ventilation perfusion mismatch can be there in pulmonary embolism. The perfusion is reduced. Whereas in pneumonia, there also you get VQ mismatch. There, ventilation is reduced. Perfusion is good. Okay.
So this patient actually.
So what is there any advantage of VQ scan?
In renal failure patients.
Second thing, they normally inject the dye from the lower limb. So the filling of the lower limb vessels also can be picked up by during the scan. Okay, so you can see whether any DVT is also there. But nowadays it is not recommended because we have Dopplers in our ER, and we have good echo. Everything is there. So nowadays nobody prefer VQ
Over
scanning or CTP.
CTP. So ideally, I say absolute indication for a CTP will be like any cardiac arrest, any persistent hypotension, any impending respiratory failure, or any acute like right side heart failure, and also persistently elevated cardiac enzymes. But this patient actually we mainly went for thrombolysis because of a significant clinical persisting symptoms like persistent hypoxia, tachypnea, and also echo showing RV dysfunction.
Okay.
So we plan her for the thrombolysis. Thrombolysis we initiated with Altiplace. Altiplace 100 milligram was given over a period of 2 hours. And
what is the difference between thrombolysis in myocardial infarction and pulmonary embolism? Is there a difference?
the dosage actually we use double dosage we use.
Dosage is different from normal myocardial infarction to pulmonary embolism.
And also, suppose that we are planning for a thrombolysis, we have to first initially think about the contraindications. One should be any recent surgeries in the recent past, or any history of an intracranial bleed or anything in the recent history. And also, patient is actually having uncontrolled hypertension during this presentation, and also any metastatic cancer. You can also have like rebleed or something if you're giving thrombolysis.
Okay.
So the contraindications I have to think about before starting thrombolysis. Once we are initiating thrombolysis, we have to continuously carefully monitor the patient because any sudden drop in GCS or anything, we have to think about a spontaneous IC bleed, then we have to immediately go for CT. And also, if the patient on initial arrival had a history of any fall or syncope or anything, it's better to take a CT before the thrombolysis to rule out any IC bleed. And so once this is initiated for the next 24 hours, we have to avoid any arterial prick or anything for the next 24 hours. And once the patient has been hemodynamically stable and uneventful, we can start her on the next drug, that is anticoagulants. So this patient, initially we start on thrombolysis of Altiplace, 2 hours we give with 100 milligram. And then after 20...
What are the things you monitor during thrombolysis?
One thing is actually basic vital signs, that is heart rate, blood pressure, and oxygenation is SpO2. And also we have to connect a cardiac monitor to look for any arrhythmia. And also we have...
Most important is what?
GCS.
Most important is?
Important.
Allergic
reaction.
See, any drug, including these thrombolytic drugs, most important thing is anaphylaxis. So, as an ER physician, it is more important. Okay. Other things, bleeding, all these things can occur. Okay. So, hypertension should be monitored first. Okay. So, you have to be very closely monitoring the patient who is getting thrombolysis.
Okay. Once the initial thrombolysis is over, again we have to continually monitor the patient for the next at least 20 to 48 hours. Very close monitoring should be required. And also then after 24 hours, we can start the patient on anticoagulation with Clexane, enoxaparin. The dose will be 1 mg per kilogram, which we can give as a BD dose. So Clexane usually comes in 0.4 and 0.6 ml, that is 40 milligram and 60 ml. Okay. So this patient we went ahead with 0.6 ml BD, that is 60 milligram BD dose was initiated. Okay. And by the 70 means after 3 days, that is
what are the contraindications for Clexane?
Clexane again we have to enoxaparin. So we have to, before starting Clexane, we have to note any renal failure or any renal dysfunction. Then we have to go for heparin.
Okay.
So in case of any renal dysfunction, we have to go for heparin. The unfractionated heparin, the dose will be 80 milligram per kilogram as a bolus dose and 80 mg per kilogram as an infusion we can give. Okay. Or if you want to go for sub-Q, we can go 5000 international units TID we can give. So that will be for patients with renal dysfunction. All other patients, preferably we go for low molecular weight heparin. Okay. So this patient, initially we give a thrombolysis with Altiplace, then we started on Clexane BD with 0.6 ml, and then on the third day we started her on warfarin. Okay. Warfarin we started.
Ideally, it has to be started on the same day.
Same day.
Along with the heparin, you have to start warfarin. Okay. So you should remember that. Then only start routinely. If you are getting a pulmonary embolism after your thrombolysis, when you are starting heparin, along with you start warfarin, because it takes some time to act.
Okay. So as a bridging, we'll continue the anticoagulant, and along with that we start warfarin. So our range will be to keep the INR between 2 to 3. Okay. And once the INR is reached, we stop the anticoagulant and continue with warfarin for lifelong.
Is there any difference in warfarin versus non-vitamin K antagonist?
Novel anticoagulants.
No. Okay. Is there any difference?
Monitoring.
Monitoring is not required. That's all. Okay. In action-wise, all studies, most of the studies proven that warfarin is still better than novel drugs, but we no need to monitor. But even then, patient can. Now we are seeing
with
patients are
complications,
presenting with complications of the drug. Okay. So there is no added advantage of any of the new drugs to warfarin.
Okay.
So what dose of warfarin you started?
7.5 milligram.
7.5.
You can start with 5 to 10 milligrams. So we started around 7.5 milligram.
Okay. Ideal dose is start with 10 milligram and taper down. But most of the doctors prefer to start a lower dose and taper up. Okay.
So range will be like to maintain like 2 to 3 again.
Okay.
So after thrombolysis, actually by the next day she clinically improved. Her O2 requirements started slowly coming down. Actually, her breathlessness was also getting controlled. And now currently she's undergoing a treatment in ICU.
Okay.
And during her evaluation, actually, even though this patient we couldn't find any initial trigger for her pulmonary embolism. There was no recent surgery history. There was no history of any bedridden history or anything. So we went ahead with actually ruling out other causes also. Like we went ahead for a bilateral Doppler scan was done to rule in a DVT, and also we sent for markers to rule out malignancy. And so far the all
What
reports.
malignancy you want to rule out?
Any like intra-abdominal
Okay, gynecological malignancy. That is very common at this age for a female patient. Okay.
So far all the markers reports have came to be negative. But after thrombolysis, she has clinically improved.
Okay.
So we
If there is a malignancy in the abdomen, how do you treat that pulmonary embolism?
we have to continue the anticoagulants.
IVC filter. IVC, we cannot thrombolyze because the thrombus is not produced by a actual thrombus what we are discussing. It's a malignancy induced thrombus. So IVC filters are the treatment of choice. But anyway, we'll be trying heparin or warfarin, but it will not work. So filters has to be used there.
Also, the anticoagulant therapy may have to be continued for a long time in case of malignancy induced pulmonary embolism.
Okay.
So that was the like what happened to this patient. So now she's
other investigations and for
Homocysteine was sent.
serum homocysteine, hyperhomocystinemia cancer. Okay. That is for malignancy. Okay.
What we shouldn't be sending is a protein CNS antithrombotic.
It is not shouldn't be sent. We can send, but if there is a protein C, protein S antithrombin deficiency, when there is an acute thrombus, it should not be taken as a deficiency. We have to recheck it. Normally, every doctor will send all this investigation. But when there is a thrombus, what happened to protein C, protein S and antithrombin?
naturally
Normally, they will be utilized for autolysis. Okay, so their levels can be sometimes low. Okay, so if it is a normal protein C, protein S and antithrombin 3 during investigation, that can be taken as normal. But if it is low, then you have to note it and you have to do it after some time.
Okay. So this was the like what happened to this patient, and she is currently undergoing a treatment.
Okay.
So suppose the patient is coming to rehab with complaints of acute onset breathlessness, and she's not clinically correlating her like other symptoms and other findings. We have to think about a condition like pulmonary embolism.
Okay.
So we can initially go for well scoring. Well scoring is actually we have different points. One is any suspecting a DVT. That is one. So next is any alternative diagnosis other than PE for the patient. Suppose the patient is having suspected DVT, we give 3 points, but we can't think about any other diagnosis than PE, again 3 points. And on initial arrival, heart rate was more than 100, we going 1.5. And any previous history of thromboembolism, again 1.5. Recent history of any surgery or bedridden situation, again 1.5. Any active malignancy, 1. And hemoptysis on arrival, 1.
So if we see the score of this patient,
this patient actually,
what is the score?
Only thing is elevated heart rate. And
so that is a problem of scoring system. You should have high index of suspicion in this type of cases. You may most of the time what happens is we'll misleaded by the clinical little symptom what she is telling. We'll make it as a diagnosis of pneumonia. Okay. Most of the time this diagnosis will be missed if you only follow the criteria. Okay. Criteria are good for an inexperienced doctor. But if you are experienced, again you need to look for other features of pulmonary embolism, like you have to look echo and other adjuncts. Okay.
So if we come strictly following the criteria, we only have a positive finding of a heart rate more than 100 beats per
That's
minute.
all, yeah.
That's all 1.5. That's like a low risk condition.
Okay.
But clinically, if the patient is having
And this patient
symptoms,
does not have any risk factor. Non-risk factor is not there.
so again, clinically, if you're suspecting pulmonary embolism and the scoring is again negative or less than 2, we can have one more scoring. There is PERC. There is pulmonary embolism rule-out criteria.
Okay.
In that, one thing is clinically low probability for any other condition. There is again 1 point. Any age less than 50 years, then on arrival pulse rate less than 50, then pulse oximetry more than 94% on arrival. No hemoptysis, no previous pulmonary embolism history, no surgical history, no history of any estrogen use, or any no unilateral swelling on arrival. So basically, any of this point is positive, then there is again still a possibility for pulmonary embolism, which we have to evaluate further. But all these criteria are coming to be negative, then we can most probably rule out pulmonary embolism.
Okay.
There is a PERCS criteria. So initially we can go for a Wells criteria. If it is again showing like a higher risk or a moderate risk, 2 to 6 is moderate and more than 6 is a high risk, then we have to go for further evaluation. But less than 2, we have to go for PERC. PERC again is, if any of the, at least one is positive, we have to think about further evaluation. Negative, the probability of pulmonary embolism is very low.
Okay.
So we have to think about other causes for the acute blood
What
vessels.
about echo? Is it diagnostic in all pulmonary embolism?
And only if it is affecting the main thrombus, then there will
If
be
it is a massive
dilatation.
pulmonary embolism, only you get all the findings which is described in books. Okay. If it is a small pulmonary embolism, or if it is a repeated pulmonary embolism, you are likely to miss the diagnosis. Okay. What about ECG changes?
ECG, the most common change will be sinus tachycardia.
Okay.
And when less than 20% cases, we might get the classical S1, Q3, T3.
Okay.
The S wave in lead 1 and Q3 and T3 in lead 3.
Okay.
That may be seen.
And RB may be.
Then RBB may be there.
But the S1, Q3, D3 is positive only in very few, 15 to 30% maximum.
Okay. So this patient actually we were able to manage like in a proper this thing. But some patients they may not be able to we may not be able to like manage with thrombolysis and all that. We have some other options.
Okay.
That is one is catheter directed thrombolysis. Suppose the patient is having like an intermediate risk for pulmonary embolism with a good hemodynamic parameters, but the patient is having an age over 65 years or has a high risk for bleeding, like intracranial bleed and all that. So we have to think about pros and cons. If you're giving thrombolysis and you finish like putting the patient on an ICU bleed and further complications, and if you want to avoid that, we can think about catheter directed thrombolysis.
Okay.
More like we go for a PTC in the CAD patients. We have a catheter directed thrombolysis again, but the only issue is actually it will take some time to arrange and prepare the patient. So we can assess the patient with pros and cons, and if the patient is coming into that category, we can advise that option also. And also in case of massive thrombus, we can also have an option for surgical embolectomy. There is a patient is having like significant hemodynamic instability and all that, but again having high complications we are expecting in case of thrombolysis, we can go for surgical embolectomy. That are another options available. And also a patient coming with this thing, probable pulmonary embolism, our initial management will be like clinically we assess the patient and rule out other causes. Then probable pulmonary embolism initially will be like D-dimer. Then we go for CTPA. But some patients, if you're not able to do CTPA, we can go for ventilation perfusion mismatch. Okay. And rarely, some patients we may not be able to do both, like in pregnancy and all that. Secondary one option will be MRI. Okay. MRI is actually on studies have shown like low sensitivity and specificity, but as a second line of treatment modality, we can diagnostic modality we can use MRI.
MRI, what is the problem in the lungs?
MRI mainly this thing. The lung movement can actually
movements will alter the signals. So any moving objects, it is very difficult to monitor by MRI. Okay. So they are not good choice in pulmonary embolism.
So as a second or third line, we can go for this. Okay. And also in ER, actually we can use our lung ultrasound to rule out any other causes like any consolidation, effusion, or we can immediately rule out in ER. And also patients who are having pulmonary embolism, we always have to rule out DVT. For which we can use bilateral Doppler.
This patient?
It was negative. We did the Doppler, it was negative. Okay. So these are the basic things actually we do in a pulmonary embolism.
So how long you continue warfarin this patient?
Lifelong.
So we are not able to find out the reason. So this patient may require lifelong warfarin
access.
Okay. Anything else? Anything else you want to tell?
Thing is actually it's not like in patients who are for after boundary embolism, but suppose the patient we are starting on anticoagulants. There is something called a Hasbroad score, which predicts actually any chance for bleeding in the coming years. So it has certain conditions. Hasbroad is actually an abbreviation for hypertension, abnormal renal or liver function, then any recent stroke, bleeding, or any labile INR values in an elderly patient like more than 65 years, and also in history of ethanol intake. So in that abnormal renal or liver function and drug intake or alcohol intake has a point of 1 or 2. All others have a point of 1. And the score coming like it has a grading from 0 to 5. And as the score increases, the chance of bleeding or complications occurring in the coming years like increases. Like in 0 or 1, we'll be having like 1, 1.2 like that. But coming to like 0, 4 and 5, the chance of getting a complication due to this anticoagulant will be like 10 to 12%.
Okay.
That's a scoring we can just use to assess the patient, considering his other age and parameters. So this patient, so over time he has clinically improved, and now actually we weaned her off for NIV, and also she's only maintaining with 1 liter O2 on nasal prongs. That's the current status.
Oxygen is required for this patient. 1 liter oxygen.
Tapered or oxygen doesn't really matter. Even
after
Liter
that,
is nothing.
nothing,
It is less than room air. So you can stop
Completely
it.
stop.
1 liter oxygen is given only for doctor's satisfaction, not for patients. But it will not give any benefit. Okay.
So
Movements. Will you advise movements for this patient?
intensive spirometry has to be done.
Movements means mobilization of patient.
Yes.
yeah, mobilization we
And
can
DVT again.
You can ask the patient
mobilize
to
as
mobilize.
early as possible. We can mobilize the patient.
There is no active inflammation in the body, or like DVT with active inflammation. Patient should be mobilized. Okay.
Also, in cases like DVT in pregnancy, also that management of this thing will be the same only.
Okay.
We have to give anticoagulants, thrombolysis if indicated, and also in like in the acute conditions where we are not able to do any of this condition, we can even go for an ECMO,
Okay.
extracorporeal membrane oxygenation to like to save the life of the patient. We can go for that as a temporary measure.
Okay.
That's one extreme condition like sometimes can happen.
Okay.
So this patient is have clinically improved and now
How is she now? We are discharging.
plan to discharge. Yeah.
Okay. Warfarin 7.5.
7.5.
What time you are giving warfarin?
6 p.m.
6 p.m.
Evening. Okay. What are the advice you give when the patient is on warfarin?
Drug interactions.
So whenever patient takes new drug, that has to be checked by the physician, whoever is giving. That is the main thing. Okay. If the patient come back with a bleeding tendency, what you do?
If a bleeding tendency, then it again depends on what is the real
INR.
INR.
Okay.
If no bleeding, if bleeding tendencies and the INR is high, we stop INR and then we give
Stop the drug.
Stop the drug and then we give
Vitamin
K
K.
and
Okay.
FFP.
Okay. So you can reverse if required. Okay. Okay. Thank you.
Thanks.